Well, welcome tonight. I think we probably could get started. I see that we're being joined by participants. Welcome, everybody. My name is Dr. Sheila Morrison, and I'm here to moderate and facilitate a conversation with one of my dear colleagues. I practice in Calgary at a busy specialty lens site, and I've had a wonderful time over the years using the ESP and dozens of other different types of technology. One of my favorites tonight is looking at aberrometry in practice. And so we're honored to have Dr. Jenny Wong here. Jenny, could you say a few things about yourself? Because you're kind of a hidden gem. Could you tell us kind of the highlights of your career and sort of where you're practicing at now?
Oh, thanks. Yeah, I'm out in Vegas. A little bit warm right now, but I
What's the
worked at the
temperature
conference.
today?
It was like 80s Fahrenheit, but it's slowly getting up. I think last week we did hit 90s. Eventually it'll hit 120, but it just kind of comes with the territory.
Fair enough.
Yeah,
So,
so yeah.
So we have a series today, including case reports and conversation, and we're going to go back and forth just a little bit. And so we can advance into kind of our intro section, where I'll introduce a few things. Now, one of our topics that we all agree has been become kind of on the main stage, is higher order aberration. And the really interesting thing that we have seen over time is a huge influx and sort of take up in moving the technology from a research setting into something that is really available in a way that's more easily accessible for practitioners to do more for our patients. And we're really looking today at, why does it matter now? We have really come through a place where things have changed a lot, and we're able to put technology together using corneoscleral data to really understand ocular shape in a better way to make better choices, with our lens fit. I don't know about you, but over time, I've really gotten to have a really smooth process in the clinic for high quality data acquisition, really sharp decision making because of that data acquisition that has either, gone one of two ways. You're using the tech to choose a starting lens and get a diagnostic fit done quickly, or we're using the data to literally design a lens that is based off of scans of the ocular shape. And that really has allowed us to focus more on optics. And so now that we're at a place where our fits really are optimized to a higher level than they ever have been, the optics in the higher order aberration now matter more, even more than they ever have before. Now, I want you to talk a little bit for us about the OVITZ xwave system. In this presentation, you know that that's what you're here to do. And overall, we're going to share how we can merge technology together and really create these perfect fits. I mean, it's not always perfect out there, but we're getting as close as we ever have been to being able to create these devices that are lightly touching toward perfection. It's becoming something that we have not, I don't know, in your practice, would you say that using technology like this is something you do offer for everybody? Is it mainstream? Is it not? I mean, that's for everybody to decide. In your office, do you actually, I'll have you go through these cases. We'll move into this presentation looking at how do we control higher order aberration with X-Wave as well.
hmm Yeah, yeah. Thanks for the introduction, Dr. Morrison. So yeah, our goals with this session is definitely to build that foundation on understanding what HOAs are, um, and how they function. And then we'll talk about the clinical applications of, wavefront guided scleral lenses and how they fit into a clinical setting. Because all of this is still really, really new for a lot of people. I know you've been doing it for so many years. But I'm going to try and start from, the basic foundations to get everyone on the same page at least. So I do want to start out with the case, and I feel like this is a similar case with that a lot of people have gone through, and I feel like probably for you too as well, Dr. Morrison. You have a pretty young, m- patient. I have a Hispanic male. He's a CPA, and he was diagnosed with keratoconus. He got cross-linking in 2020, and then he will get crossing in 2021 at the time, kind of reflecting. And his slit lamp examination, he has some central striae, some mild stromal haze. Left eye is worse than the right eye in terms of VA. So uncorrected, he's about 20/40 right eye and then 20/100 left eye. So he was referred for a scleral lens fitting, and obviously the goal is to get him better vision. And so diagnostic lens goes on, actually a really great diagnostic lens, super easy fit. And even with that lens on, he was 20/30 in vision. So in a lot of situations, what are we kind of thinking? In 2020, I was like, awesome. He's better than 2100. He can get a driver's license in Nevada. But it is a little bit strange in terms of his visual findings aren't super significant. He didn't have like super crazy keratoconus. Um, so, why can't he get better vision? Did you have a lot of these cases, Dr. Morrison?
Always. I mean, it's a classic, right?
Yeah, yeah. So at the time in 2020, we had just gotten the OVITZ. So we're like, hey, let's just try it out. And so we did an aberrometry scan on this patient, and this is what his HOAs look like. So we can see that he has this one large peak, which is where this red circle is, and it's past, the horizontal red line that says significant. And so this large peak correlates with what we call Z7, which is vertical coma. And this is pretty significant amount of vertical coma that's contributing to probably the bulk of what his HOAs are in his eyes. So I'm just going to backtrack a little bit to what are aberrations. So aberrations are any deviation from perfect focus. So if there is no aberrations, it means all the light rays are focused perfectly on a point. When we have something like refractive error like myopia, that's when the rays are all focused on just the wrong point, but still together. Higher order aberrations is when all the rays are focusing on all different points all over the place, so very irregular pattern. So even though the rays of light are focusing in an irregular pattern, it can technically be broken down into like smaller identifiable patterns, and that's what this pyramid is. So this pyramid relates to kind of what we do every day with glasses and soft contact lenses to what wavefront technology is. So sphere and regular astigmatism, prism correction, that's considered lower order aberration, which is that top half of this pyramid. When we get down to the below the third order, which is, one, two, three, and then down into the fourth order, that's when we start looking at higher order aberrations. And you can kind of, when you're looking at these patterns, you can kind of see based on the color how much more complicated all those patterns get, especially as you move down that pyramid. And um, let's see, yeah, the HOAs, the higher order aberrations on the bottom of the pyramid. And then for me, in my simple mind, I kind of wish they flipped it upside down where the higher order aberrations are higher up on the pyramid. But basically, each one of these individual patterns are called Zernicke coefficients. So they are measured in microns. And when we quantify the total HOAs present in the eye, we're going to refer to that value as HOA RMS, which is root mean square. So clinically, we will treat this like an average, but mathematically, it's technically not an average, just something to kind of be aware of. And in clinic, our goal is to reduce the HOAs. So crush with those HOAs. And so Dr. Morrison touched base on why it's important to understand HOAs. Another reason is just patients. Patients are doing a lot of their own research. And this is a super awesome slide that Dr. Noha Saif created. She's from Contact Lens Institute of Seattle when we were collaborating on a GSLS lecture. And it's about, what patients or future patients are talking about. And it's so valid. A lot of these patients find the need to educate themselves on their vision problems. And reading some of these, it does seem like some of them have experienced interaction with an eye care provider who doesn't know that HOA correction is possible and is currently existing. So why are these patients so motivated to know more about HOAs and what HOA correction is? Patients with HOAs will experience a whole variety of vision issues. So such as blurry vision, there's double vision, glare and streaks coming off of lights, starburst pattern, all the different combinations of these, visual distortions. And so even for me, I'm looking at this picture and it makes me a little bit woozy. And this is probably the visual experience that somebody has been experienced for years and years and years. It can be very debilitating. So a lot of these patients are very motivated to try and find ways to improve their vision. Dr. Morrison, how do your patients bring up HOA symptoms to you?
Really commonly, they'll express difficulty with night driving. That's a big one. And they kind of just like present with that 20 unhappy. We've talked about that a lot over the years. It's definitely true. Starburst, some of the things you've mentioned already, that kind of streaking of light. And yeah, I cannot emphasize more how much more I agree with you. It really resonates that it's a population that not everybody needs HOA correction, but those that do, man, that makes a huge difference in their lives. And I loved when you talked about empathizing with them and looking at their experience and their complaints. I mean, the world we live in is very competitive. Everybody wants to be heard. Everybody wants to feel validated in their journey. So, yeah, it's something that it can be subtle for some people where you're not getting a slam dunk with your optics, even though you believe that you've done your superhero. You got 20/20 or 20/25, and they're unimpressed. And if you dig a little
Mm-hmm.
deeper, sometimes it comes from aberration.
Mm-hmm. Oh, I agree. Um, ooh, and ghosting too. So yeah, these are words that we use quite often, but I'm sure in your experience, Dr. Morrison, it's not in their patient's normal vernacular to be like asymmetric blur and double vision or even quadruple vision. So sometimes it's really hard for patients to describe what their vision is. I've gotten just the or things to look out for is like migraines and headaches and just, patients who are just not happy with their vision, even though objectively, like we can probably say that they have great vision. So, some of these patients, they just get kind of pushed to the side,
Mm.
unfortunately. And as you mentioned earlier with the night vision, HOAs are pupil dependent. So the patient might not have a lot of big issues during the day or in bright lighting, but then, maybe ask them what their nighttime experience is. They might be a lot more symptomatic. So even on the scans as well, if you're doing aberrometry scans, you're going to pick up more data when their pupils are dilated. So this is an image in terms of, let's say like a normal eye without keratoconus, the letter E gets a little bit worse, but it's still read legible. And then you have a patient with keratoconus, and as their pupils dilate, that HOA RMS is significantly increasing to the point that it's really hard to identify what that E is. So where do HOAs come from? Um, let's see. Well, they come from the cornea. So you have the front of the cornea, you have the back of the cornea. It can come from the internal lens inside of our eyes, both the front surface of that one, the back surface of that one. The size of your pupils play a big role, but also the type of refractive correction that this patient is wearing and how that lens is fitting. And so this was a really great picture from Dr. Safe, how the kind of scarring kind of matches up with the HOAs too. So in general, like everybody has some degree of HOAs. You can't really get rid of it. We're just hoping that we can reduce it to a point that they're less bothered by it is the goal. And then um, the first bullet point actually is regarding like advanced keratoconus. This is from a study where basically, the epithelium kind of grows to compensate for the thinning stroma, and it grows unevenly. But the end result is that you have a pretty smooth anterior front surface. But then that doesn't mean that the posterior corneal surface is smooth and perfect. A lot of times that posterior cornea is going to be quite different from the front surface. And internal lens, we have lenticular stigmatism versus corneal stigmatism. We all kind of learn about that. So sometimes when you're correcting with the scleral lens, you might get, potentially worse vision, and it might be because of that. Other things in regards to contact lens and HOAs is, if the lens is decentered, if it's rotated, if there's tilt to it, flexure, lens material, poor surface wetting, all those can contribute to more elevated HOAs or, just poor vision in general. And yeah, the posterior cornea plays a really big role in HOAs, especially for keratoconus, where we can see the changes happening in the back surface, much worse than on the front surface, especially with the advent of tomography scans. So with the scleral lens, we're smoothing out that front surface irregularities, but not the back. And this OCT kind of can show what that, sometimes is noticeable like this, sometimes it's subtle, but you can see that the curves are quite different. And so patients are going to be affected visually by those irregular optics. Let's see. So depending on the eye condition and the lens and then how that lens is fitting, sometimes it could result in worse vision. Glasses just sit in front of the eye, so the whatever HOAs are in the eyes are in the eyes. Then you kind of have a soft lens, for example, and the soft lens has the optic zone, it has refractive power, and then you put that lens on an irregular shaped eye. Now, and that lens is no longer fitting the way you want it to fit. So now light is going to focus in a pattern that's unpredictable, and you can have worse HOAs now. And then scleral lenses too, if that lens is ill-fitting, it's way decentered, it's got flexure, it's got all those things happening, that can also induce more HOAs as well. So Dr. Morrison, have you seen that in action where you put a better fitting scleral lens on the eye and their vision is better than a poor fitting scleral lens?
Yeah, and depending on
Yeah.
the optic, as you mentioned, I mean, one of the foundations of being able to successfully neutralize with kind of essentially a wavefront optic would be stability and having that placement right over the visual axis. And I think as long as you're consistent with the fit, so I have noticed absolutely with and works with multifocals too, depending that position if it's not in the place that you intend it to be. And so one key that I think we'll probably repeat because it's such an important one for those interested in fitting HOA is wherever you go and whenever you're ready to start with your HOA measurements, make sure you have that stable device. So if it's a little decentered, it has to always be in the same spot. If it's a little rotated, always in the same spot so we know the base is stable. That way we can build that complicated optic to neutralize in the position that we want it to. Because to your point, when we have a lens, we put that optic and it decenters or it's doesn't do what we want, actually can create worse vision in the end.
Yeah, I definitely agree with that. Lens stability and a great fit goes a long way, which is why profilometry is a great tool, but we'll talk about that a little bit more later. Oh, and there. So yeah, how are aberrations measured? They're measured with something called an aberrometer. So this laser, or sorry, this instrument does send a laser out. It's a safe laser, and it goes through all the different layers of the eye, and then it bounces back. And then there are sensors that collect that data to show to show us how that light is reflected back in the eye. And one of the data points that you get back with the OVITZ in particular is a wavefront map. And so you'll see a lot of these kind of images when it comes to wavefront optics and, posters and lectures and things. So this map helps, us visualize what the combined HOAs look like. And, if we take a look at this map, we can actually break it down into individual Zernike values too. So this particular one it's made up of, if you combine coma and trefoil, we kind of get this total HOA wavefront map. And it could be broken down into a bar plot. So that's what's really helpful is that we get this really crazy pattern of, a patient's wavefront map. And then we could break it down to which particular Zernike values are causing the most impact to their vision. And this graph is generally pretty easy to look at. You can see the taller peaks are higher magnitude and, probably affecting their vision more. And then don't confuse the map because there's a lot of colors going on with all these different scans. Just keep in mind that they do very different things. So corneal topography and profilometry maps out the shape of the eye, while aberration measures kind of that refractive and aberration data. So one is like shape, one is vision. And how wavefront technology works is that we basically measure the HOAs that are present in the patient's eye, and then we'll try to neutralize those HOAs with kind of the opposite value, similar to how myopia and minus lenses, the eyeball's too strong, so we try to push back that focal point, right? And yeah, once we neutralize it, hopefully get a more even pattern of their wavefront map. And this bar, the blue peaks are of the patient's uncorrected HOAs, and then the red peaks are what the HOAs look like after we had put that neutralizing patch on there. And this is a really good correction. Like I said earlier, we can't get rid of all the HOAs that are present in the eye. But that's basically how wavefront technology works.
Can I ask a question about those bar graphs? So
Yes.
when you measure a patient, and say if we don't have the red yet, we're just looking at our blue, which is our lower order lens, basically. Do we
Mhm.
want what is a better candidate? Whole bunch of bars that equal up to a high RMS, or several large bars like what is seen in your graph, where there's a couple big blue ones and everything else is contained?
Yeah, that's a great question. I don't want to say easy hitters, but the patients that probably have the best subjective and objective responses, typically there's like one to three big, large peaks. Because technology-wise, it's quite easy to kind of target kind of these small individual ones. When they do have, an irregular pattern, there's a bunch of high ones and everywhere scattered, it's kind of hard to accurately correct all of those because we'll talk a little bit more in terms of how the patch sits on the eye and why lens stability is important. But when you have one or two, it's generally a little bit easier than if you had a bunch. Just kind of how stable that lens is plays a bigger role.
So
So
you
that's
call
a
those
great
your home run patients. Couple big
question.
bars, high
Yep.
RMS, those ones. That's a great option to start with.
Yep, yep. And then sometimes you can look at some of these bars and you can kind of tell this is a keratoconic patient with that significant vertical coma.
Hmm.
Great question. And then, yeah, this next one's for you too. So HOA correction in general, anyone with high HOAs, there are complicating factors to keep in mind. Um, but for me, if you think they have a condition that can improve in a refractive sense, they might be worth targeting. Um, so I'll just kind of read down the line. So just kind of more challenging patients, intacs, corneal scarring, high drops, dry eyes. Those you might get kind of a more, multiple different peaks in different areas. So those are going to be a little bit harder patients. Doesn't mean that you shouldn't do it, but if you're more confident, more experienced, those are probably be more suited to you. And if you're starting out, you probably don't want to start out with the more, those type of patients. What are your thoughts
What are
on?
your thoughts on cataracts? That was one that came to my mind. I'll tell you what I do, but I want to learn from what you're up to.
Oh
Is that a contraindication, like mild cataracts, and people are bothered by that aberration?
yeah, I feel like I have a really boring answer with this. I scan them and kind of see how high their HOAs are. And depending on if they do have a quite elevated amount, because, even to this chart, less than zero point 0.3 on a normal healthy eye, they might not notice a big difference. So if that patient with cataracts has, more than zero point 0.7 and certain large peaks, I would feel more comfortable and be like, you can probably get a little bit better vision. I think tempering expectations is a big thing, how good that scan looks, and just what our HOA data is. What are your thoughts?
I have done a few and it's fine for a bit, but I do find that if it is a cataract that's at the phase where it's progressing, then the next thing you know, it's like they're needing another lens again in 6 to 12 months. And so it's kind of like that phase of when you have a patient, even with their glasses. So the way I've handled that, though, to be able to proceed with these patients that need medically necessary lenses, there is a time period where you have to make friends with those cataracts, and they're going to do what they're going to do. You may need to change your glasses a couple times before they're mature enough, and I'll teach them, although the cost can be obviously a little bit higher with a medical contact lens with aberration correction than a pair of basic spectacles. And then I leave it up to the patient. If it's really bothering them, they're a bit younger, they're not, they're clearly still 2020, they're not ready for cataract surgery this year. You warn them
Mhm.
that it could change, but the ones I've done it for sure improve their golf game.
Yeah, no, I agree. Even same thing with the dry ice too, which I know you have quite a bit of.
Strong opinions on. I'm ready anytime for that. I won't take over but on that, but whenever you're ready, we can dig into that topic at some point.
Yeah, things that have a lot of variability, it does make it harder. And then post-tier segment, in terms of like macular degeneration, glaucoma, we can't undo what their vision has unfortunately progressed to.
Right.
But the goal is, right, exactly with the cataracts, try to improve whatever vision they currently have. And so, I don't know how many people are curious about this, but sometimes the question gets brought up, why scleral lenses are the only ones that are compatible with wavefront technology. So scleral lenses have rotational stability, translational stability, up and down, side to side movements. They have a large optic zone. They're just really highly customizable to be able to get a high level of lens stability where that HOA correction can, stay where it's supposed to stay on the eyes. And that's why right now we're is only compatible with scleral lenses. Hopefully in the future it'll be a different case. But in case people were curious, that is why. And then this slide has a lot of colors, but basically it's kind of showing, what happens when you do have HOA correction and that HOA lens is moving on the eye. I'm just going to use this blue circle is the patient's eye, and the red circle is the correction, right? The opposite neutralizing patch. And if that red circle kind of moves, let's say upwards, now it's decentered. Now it's interacting with where the blue and red circles on, this first image are. And you're going to have, more HOAs. You're going to probably induce some coma, some astigmatism. So that's why having a stable lens is really important because the design is based off of the patient's eye and not where the center of that lens is. Okay, and then depending on which aberrations are being corrected, basically the higher the pattern is on the Zernike pyramid, the more sensitive it is to instability. I kind of think of this similar to, high amounts of astigmatism, smaller amounts of rotation. They're going to impact the patient a lot more than if they had, zero point 0.5 SIL. Basically, summary of that is that lens stability is super important. And then in the kind of more, I don't know, I guess clinical side of things, it's not super worth correcting, down that period more than 7 orders, just because that lens stability is like super, super sensitive. So OVITZ themselves will measure to the seventh order, but also in that aspect, it's not super important to have like an ultra resolution wavefront sensor. Um, because, I do consult with OVITZ and the goal is to be able to make something that's accessible for patients and doctors. And if we have something that's ultra resolution, doesn't necessarily mean that's providing like a lot more benefit clinically. So how do we fit wavefront guided scleral lenses? We do the scleral lens fitting. We want to make sure that fit is finalized and stable. Then we submit those aberrometry scans over that finalized fit. And then we get a wavefront guided scleral lens, which we then dispense to the patient. And then, have the patient wear it, check the aberrometry data, and see if there's any overfraction. Do you deviate from this, Dr. Morrison?
No, I mean we definitely do. Let me just go through. No, I would say generally the process is definitely the same as what you do.
Okay, perfect. Yeah, I think the most time is just getting that lens fit stable, but having a profilometer helps so much more.
Absolutely.
Yeah, speeds things up for me. And then,
Sometimes
yeah.
we'll throw in a screen or two to prime them. So before we get to that point, there's that one step of we don't actually dark adapt in this step. It's early on in the fit where we'll kind of get them prepared for contracts with costs and to set the expectation for the warranty with the manufacturer and the patient, where
Mhm.
we're identifying if we think we're going to move forward. In some cases, I just wait and get the best fit distance. Or whatever it is that they need. And then if it ends up that the finish point is not exactly what we want and it turns out that they're a good candidate, then you can switch them over then.
Mm, I agree as well. Yeah, I'll scan them and see if immediately I know they're going to be a
Hmm.
great candidate, or sometimes I'll wait until the lens is finished and it's like, hey, are you overall happy, or
Really
can
happy?
you do
Yeah,
more?
exactly.
Yeah.
Sometimes the clues too from their previous history. So I find some really, I would say easy conversions for me would be those that have had failures in other experiences. And that's not uncommon with patients with aberration because, even though a lens is fit perfectly and it's at the highest neutral optic that's possible with a standard design, it can still be frustrating for patients and they will seek other options. And that's where this type of technology between profilometry speeding up the fit and then aberrometry with OVITZ, we've seen that it really sets us apart from our competitors in a market where people are really seeking things that they have very high expectations. It's like you really
Mhm.
think that your eyes can do all those things and that little piece of plastic can give you all of that? And the answer is yes. So yeah, it's been cool to find that process of when do you screen, when do you not. But yeah, it's easy to convert those people that come with frustration already.
Oh, I think that's such a valid point, especially on the little slide with the clinical or the candidates. Sometimes if they're lower on that HOA RMS and they've been through all that, hey, it might be worth, going down this road. So yeah, one thing to keep in mind with, or not one thing, there's a couple things keep in mind with fitting considerations. Um, you know, if the lens is off, the lens itself might induce HOAs even before you start HOA correction. Check things like flexure. If there's poor tear film, sometimes you're going to get wonky data as well. And I think this applies to kind of any of the instruments and scans that we do in general, but it also applies to um, wavefront technology. And if the lens is too decentered or even sometimes mildly decentered, this is a little bit hard to see without these dots on there. But the lens could be decentered to a point where the optic zone is just kind of barely interacting with that pupil. And pupil is dynamic. So sometimes in dark environments, right, that pupil is going to get really, really big. And now they're looking through kind of the edge of that optic zone, which is going to affect the vision performance, whether or not you have HOA correction. Um, and in terms of the HOA correction, you're going to have less effectiveness if we kind of left this lens like this. It'll still be good, but maybe not the best level of success if that lens is kind of decentered. And another thing I think this doesn't happen as commonly is when you have a patient with a spherical sclera. So when their sclera doesn't have much toricity, that lens can tend to rotate a lot more. And so, you might want to kind of induce some toricity onto that lens, even if that patient doesn't have much. Or sometimes it's just hard to see whether or not that patient has a lot of toricity until, you start messing with that lens fit. One thing that really helps for me is profilometry in the situation. Have you had a lot of spherical sclerals, Dr. Morrison?
There's more than you think. Honestly, it's not, I mean, they're more irregular, they're more toric, but there's a lot of spherical eyes out there. And
Mhm.
it definitely helps us to set expectations. In fact, I have eliminated the odd patient just because of, previous history of lenses that rotate. And you can really understand why that is. Now, do you ever prism ballast to try to get it to hang in there in these cases where you can try to get a lens to be, or how's your experience? How would you stabilize a spherical shaped eye with a scleral lens on it?
Oh yeah.
Pretty
Since
tough.
I started practicing, I've been so spoiled. So I've always had a profilometer um, in our office. So that has basically gotten rid of kind of that guessing in terms of, oh, that lens is rotating on a spherical
Yeah.
sclera, what should I do?
So
But
would
I
you would you
kind of
eliminate somebody from an HOA lens if you saw a spherical shaped sclera like this picture?
Oh, good question. I probably won't. I probably, I
Try
mean,
it.
you can do prism balance. I might
Yeah,
just put
yeah.
some toricity, like back toricity
Mhm.
on there and kind of see how comfortable they are with it. And sometimes they don't mind it as much. It's not so much toricity that I'm squeezing the eyeball a certain way. That's what I've done. What about yourself? Do you prism balance a lot?
You don't have to a lot. It's the same thing as what you've noticed. You can put a little bit of toricity on almost everybody. I actually find the
Hmm.
ones that are more problematic than the eye shape being close to spherical would be the misalignment and stickiness of dry eyes. So when you have a
Oh.
patient that their tear film is not stable or they have really severe dry eye, and to your earlier slide, that kind of conundrum we face with ocular surface messing up our measurements, not only do we often get a lens that will kind of stick in a certain spot and maybe not always rotate to its home if the eye's not lubricated enough or it's very, very dry. And then pile that on top the compounding impact of having unstable tear film that's not always the same when we take the measurements and when the patient wears the lens. I am more bothered by that than the actual shape of the sclera, which there have been very few people that I've fully eliminated because I couldn't get a lens to stabilize with inducing a bit of toricity.
Hmm. I agree. Yeah, dry eyes is a menace. So yeah, with profilometry, it also reduces chair time because the data helps me really get a really good first lens. So I don't really typically have too many adjustments after that. Is that your experience, Dr. Morrison?
Yeah, good as long as the measurements are good and we're not
Hmm.
dealing with our hyper picky patients, which sometimes there's a few extra changes if somebody is very sensitive. But yeah, it's a lot better than it used to be for sure.
Hmm. Hmm. Yeah, good scans play such a big role. So even like look at the pictures, helps me notice all of the little small nuances of the sclera as well. Like this one has a pretty noticeable pink macula, but even the data is just really helpful to kind of help understand what that patient could be experiencing, even with just a diagnostic lens, if they're feeling discomfort in a certain area or not. Okay, so kind of flash back to this patient. We performed the aberrometry scans because his left eye was not super clear. And then this is what we got from the scans. And so LOA means lower order aberration. So basically the lens before HOA correction goes in. And it's pupil dependent. So at 6.3 millimeter pupil, after he was dark adapted, is about 1.35. More than zero point 0.6, zero point 0.7 is significant. And his vision was 20/20 minus one in this eye. And then after HOA correction, we got 70% reduction and brought him back down to 2015. And we can kind of see, how closely his wavefront map kind of matches the HOAs. And then after correction, we kind of see it being smoothed out so much more. And even the, simulated letter E is a little bit more visible. And this is what the pre and post plot looks like. Blue bars, significant lower. And now his residual, just the red bars, which all of them are pretty low peaks as well. And 2015, significantly less glare, ghosting. Patient's really happy. This was a slam dunk case with the individual one or two individual peaks. This worked out really well.
Those ones feel so good. I
Yeah.
have a
Oh
question
yeah.
for you. So I find even in the early days as doctors, we conceptually to try to get our minds wrapped around, okay, HOA, what is the value? RMS, what is that? What do you mean the light is like, how if I was your patient, I am this patient. You do the scan, you see the LOA. Um, Give me your spiel on how you essentially sell me on this for the value and how do you explain to me as the patient what the heck
Mm,
we're talking about? Like voodoo,
yeah.
whatever, like how do you explain it?
Yeah, it's for me, it's going through your patient or their symptoms. Are you experiencing these things? How do you feel about your vision? And it's like, oh, it's not super great. Well, for me, I do the scan and I think the wavefront map helps me a lot because I'm showing them, hey, this blue color and this yellow color, they're different prescriptions. And I'll pull out a loose lens, like, regardless of what lens we put on top of this kind of pattern of your eye, we're not going to correct your vision much more. So the goal is kind of just improving all, just similar to glass and scleral lenses, we're trying to target the different prescriptions, get it a little bit smoother so that hopefully the glare, the ghosting will improve. So that's my little spiel. I think the wavefront map helps me a lot and helps them visualize. And, it's not, and always, setting expectations, I think is the hardest part where we're not getting rid of all your glare, but hopefully a little bit less. Like, are you happy with 50% less glare,
Mhm,
less ghosting?
mhm.
Um, and so then they can decide in terms of, going over the extra time, financial, all of that. Mhm. How do you typically bring it up with your patients?
I do fall back on just a simple explanation that is, a standard optic, and we talk a little bit about how the hard lens will create a smooth surface on the front of your eye where it's bumpy or irregular, but unfortunately, that smooth plastic can't correct the bumpiness on the back, and so there's still some disorganized light scatter that will come through to the back of the eye. So when you're trying to see a clear picture, some of the light is still unorganized. And when we do the higher order aberration correction, we can identify that disarray using wavefront type scanning and neutralize that by placing a special optic on the front. And I try to keep it pretty simple and just talk about
Mm.
validating. I said, well, I can see why you're bothered by this because when I look at your map that we created, for example, this point spread that I see on your image on the bottom right of this patient, it actually validates people to see. I'll say, I could see how this would be bothersome to you. This is a computer simulated example of what you may see in certain lighting conditions. And sometimes they're like, that hook, that's what I see. Oh, thank you. Finally, somebody gets it, sort of thing. And I use that to explain the value.
Oh yeah, that's awesome. I do get to a point where I'm like, hey, there's nothing else we can do unless we try this technology.
Yeah.
I do get to that point too.
Yeah.
Thanks for sharing that.
Yeah.
And then, yeah, I think this next case is yours.
Oh, sure. Yeah. So
Oh, yes.
this is a fun case. So, it is a 24-year-old female. She presented to us traveling from another province. So she was so anxious about this appointment. She actually had to bring somebody to come with her. So this patient, high anxiety, very bothered. She did not have any visual problems, when she was 20. And then in a few short years, she really nose planted and was diagnosed with both keratoconus and Ehlers-Danlos, which connective tissue disorder that a lot of us work with regularly, that has deep connections with conditions like keratoconus due to the way that that disease changes tissue in our body. She actually had PRK and cross-linking, so some, for better or for worse, sounded like a good idea at the time. Didn't go so well with her for her. She ended up with a lot of aberration and essentially ectasia as a result of the thin cornea. And she was just very bothered by it. So her glasses gave her kind of junky vision, and monocular diplopia. So it's kind of a classic first step is what we wanted to do was kind of get to the limit of what we could do with a standard optic. And so in this case, all patients in my practice get all the measurements. So we do profilometry, we use the OVITZ to screen people. And in this case, we were able to get beautiful profilometry images and data that showed that she has an against the rules sclera. So her shape of eye is actually just perfect for a stable lens. Unlike the spherical patient that Dr. Wong showed a few slides ago, these lock and keys are really great shape for if you see it, you're like, perfect, Christmas gift early. I can fit a lens and if it's a match to this shape, it will likely be nice and stable. And then the cornea, not torque at all, irregular. And so in this case, this has been caused by her disease. Um, Often for patients that travel, so from out of town, we will utilize a freeform style lens right off the bat. We still use diagnostic lenses for patients that have never had a hard lens on their eye to determine the power, of course, but the actual fit is fastest, I find, utilizing empirical fitting. And in this case, we had beautiful data that, to your point earlier, got us to that. Our goal is always to get a great fitting lens right off the bat. And in this case, it was worked out really well for us. So we didn't have to spend a whole lot of time adjusting the lens shape. And we ordered baseline custom lenses. And I want to show you what these lenses look like for the fitting process. Very similar to the design that you used. And I have to say, one of the things that comes to mind when you had mentioned accessibility with this technology, we want the tech to be accessible, and not just with one lens design. That's the cool thing about seeing as we're talking about eaglet and OVITZ tonight is both labs or both groups are compatible with all different labs. So Dr. Wong and I, sometimes we work with the same lenses, sometimes we don't. And that is okay because this technology, the software supports, you have a lab that you love, it's very likely that they probably work with one or both of these companies. And so the dotted lenses are used to measure the position of where the distortion lies and used to fit. And so first set of lenses or the starting point in Jenny or Dr. Wong's kind of figure with the 4 steps, 4 to 5 steps, best fit distance. We get in our dotted lenses, usually with our final lens. If I'm confident with the fit, I know I'm not going to make any more changes, maybe just a small over refraction to finalize the distance. I'll order the dotted lenses at the same time sometimes. Here they are on the eye, beautiful fit, stable, which we know is essential. Next, the next step is that we then will complete our measurements with the OVITZ wave aberrometer. And they essentially do a lot of the hard work for us, all that engineering on the side with algorithms that will generate the optic. And so I want to just skip ahead to what the results were. So for this patient, she had a huge reduction. You can see again, it's this classic thing that makes you happy if you're screening a patient. Unlike one of my patients today, a dentist who had all these hopes and dreams of having HOA lenses get to this point where we're actually imaging for the baseline. Turned out she was pretty much all in that sort of in the safe range with no big bars. And I actually told her, you know what? I don't know that it's going to be as worthwhile as we think. Whereas this patient, big blue bars, we were able to successfully reduce her aberration dramatically in both eyes. I love talking about this case because it brings up a couple other clinical pearls that really do go along with aberration correction. Is that it doesn't correct everything, but it certainly in this case was able to, after just a short period of neuroadaptation, improve vision from 20/30 garbage with the help of the hard lens first and the HOA optic to provide a significant decrease of ghosting and diplopia, not a complete elimination. So that's where that expectation setting is so important. Now, here's a picture of the lenses on eye, looking really beautiful. And in this case, the process was about as smooth as it could be. Now, this patient has other things going on with her. So when it comes to connective tissue issues, there's dry eye to deal with. There's binocular vision issues to deal with. So her journey was not over, but at least then we could get her to the point where each eye could see to its very best ability. So moving into vision therapy programs is more successful. All of her other things that she has to do for rehabilitation and other her body systems were easier with vision that it was at its best. So pretty cool case.
Yeah, that's fantastic, especially since that patient traveled too. A
We
lot
get a
of
lot
pressure.
of people that travel in for these things. That's another, for those interested in sort of dabbling in this technology. Wow, way to kind of provide something that not everybody is interested in providing or able to provide.
Yeah, it really goes to show how motivated people are to kind of, have some level of vision improvement. And then back to me. So last case, this is actually a case where patient has comorbid glaucoma as well as keratoconus, and he is a pilot as well. And I feel like this type of patient occurs with everybody. But the goal is to improve his right eye vision. He's currently 20/40 in his habitual scleral lens, and then he needs 20/30 to pass his particular piloting license. And in these cases, a lot of discussion goes into, we might not be able to get to 20/30 vision because of your glaucoma. And sometimes with glaucoma, it's hard to tell what their best corrected vision can be. But patient was motivated. And so in this case, yeah, we were able to reduce his HOA RMS by 71%. And he has pretty large pupils, 7.8. So after the HOA correction, he was able to get 20/30, which was, enough for the patient's piloting license. And same thing with keratoconus, really tall peak. This one's horizontal coma in this case. And we kind of see it with, that wavefront map too. So overall, I thought it was a success, but still just letting that patient know, hey, objectively, this is like really good data. I don't think we can do anything better in terms of the refractive sense. It's probably because your glaucoma that you're limited vision. And, unfortunately, there's a chance that glaucoma can still progress. But in this situation, he was really happy that he got the level of vision that he needed. So little clinical pearls, overall 50% reduction in HOA RMS, so the total RMS is considered really good. Average is between 40 to 60% when we looked at clinical trials. And that can range too. If you're correcting someone who's like, I don't know, total RMS is like zero point 0.4 or zero point 0.3, which is quite low. you might not get 60% because that drops you down to like, you know, impossible levels kind of thing. And, not possible to achieve zero RMS. And then when we're looking at these plots, when do we feel like we did a super great job? When all those Zernike peaks are less than zero point 0.2, that's super awesome. We don't always get that, but when it does, hey, let's just check for overfraction, or that might be the limit of this level of technology. And clinical cases, super great. Dr. Morrison, I know you love them too. This one is done by Dr. John Gellies. So definitely, feel free to read on your guys' time as well. But what was really great about this study is that it was a prospective study. And basically, the goal was to see if wavefront guided scleral lenses worked and if patients even like them. So this was random, double-blind crossover. Basically, the patients wore one type of lens, no HOA correction for 4 weeks, and then they wore the other lens with HOA correction, or vice versa, for 4 weeks, which gives the patients enough time to neuroadapt and trial the lenses in real life to get a solid opinion on this. And I don't think any diseases were excluded from this. So he was trying to get as clinically real world as possible. 31 eyes of 18 patients, age range from 22 all the way to 63. Majority of them had keratoconus. A couple of them had post-refractive ectasia, and then two of them had corneal transplants. Um, you know, Great thing about this study is that real world setting. So, it could be your clinic, it could be my clinic. These patients were non-dilated, so they're all dark adapted. And then the most important thing is that, it utilized technology that was currently available and that patients could all benefit from now. And, most of the patients, all the patients improve by at least a line. I don't always go for line improvement as long as subjectively the patients are happier, but average RMS is 56% decrease reduction, and 94% of the patients liked it. Basically, all of them except one. I think that one patient was a little indifferent between the two lenses, and he didn't care for the extra time or money. So patients with irregular corneal astigmatism, these lenses work really well. Most patients prefer this lens over a regular LOA lens or non-wavefront guided scleral lens. And this is currently achievable in, your clinic today if you decide, to embrace, to be able to handle, to want to do HOA correction as well. And then another case, this one's a fun case from Dr. Clark Chang. He's at Wills Eye. And this was kind of eye-opening. He had a patient who had, pretty significant HOAs, and she was 2070 in her GP lens. And then with the scleral lens, she was 2100. She has keratoconus with intacs removed. And then he had dispensed her HOA lens and she was seeing like much worse. She was seeing like 2100, which is worse than her regular scleral lens vision, which was 2100. And objective data was really good. We can kind of see these peaks. I know it's a little bit small, but quite a bit of reduction. I think it was 37% reduction, almost 40% reduction in HOAs, and no overfraction, nothing. And then patient comes back 2 months later. And I think 2 months because of scheduling issues, but she ended up being 2025 at the follow-up. So that's quite a big difference. She had a small overfraction and improved to 2020. Basically, from this case, if you are doing HOA correction or if you know about it or a patient's friend, somebody's talking to you about it, it just takes some time for your brain to kind of get used to this difference in optical quality than they had, in all their years before. Okay, and then take home message. Spit is super important with HOAs. HOAs are pupil dependent. Take a look at the fit because even before you do HOA corrections, a fit is so important to try and maximize their level of vision. And then things like profilometry can help really speed up that scleral lens fitting and also reduce chair time. And Dr. Morrison, you want to add more to my rough summary?
I think it's great. I have in closing, a couple questions come to mind for me, for you, and two things that you and I have both talked about or used the word neuroadaptation and then dark adaptation. So, as far as our neuroadaptation, we routinely talk to our patients that there could be some adjustment period. We do this with multifocals. We tend to do you have an amount of time that you require your patient to give it a shot, or is there a point where you can tell it's just not going to work? Any tips there?
Mm, yeah, that's always hard because, if they are having blurrier vision, they're less likely to want to wear the lens. We'll always check overfraction. If there's no overfraction and the objective data is good, I kind of
Hmm.
let them know, hey, it might take like 2 weeks.
Hmm.
Um, for your brain to kind of kick in. You've been looking at this level of glare, coma, ghosting for so long, your brain might not like it. So really talking to them. And if they don't like it, sometimes I talk to the lab about undercorrecting HOAs as an option too.
Soften it
Um,
up a little bit.
uh-huh. Yeah, make it less jarring for them. And then typically, yeah, after a while, the patients, they kind of understand it as a process. And I think setting those expectations before you dispense the lens and start HOA correction is also really helpful in that situation.
Amazing.
So a lot of the times they do improve. And this happens to me with just dispensing their first scleral lens ever, that they'll also notice ghosting and they'll mention some things. But yeah, it's really trying to get them to wear that lens.
And then during the process, the part of dark adaptation happens when we will seat a patient in a room because why and how long. So what we're talking about when we say dark adaptation happens in the screening appointment and also in any measurement where we're using the OVITZ to take a measurement to measure the success or what HOA is needed. So that's part one. How long do you dark adapt? Do you dark adapt all your patients? And then also in your practice, do you dilate for your measurements?
Oh, that's a great question. I dark adapt them for maybe like 5 minutes.
Mhm.
I just have them sit in my testing room, doors closed, all the screens closed too. And I make sure that they're not playing on their phone during this process too, because it's hard for some people to just sit still. And I'm just like, hey, just relax. We're trying to get that pupil as big as possible. And that's really important that we try to do this at every scan
Mhm.
because the only way to, you want to compare apples to apples. So the pupil is
Mhm.
a different size with every single scan. You can only measure it to the smallest pupil. So that's really important. And then what was your second question? Oh no, I don't really dilate. Partly is because that patient's been wearing that lens for a while. I don't really want to take it off and then put in a drop and then wait longer. Um, if I did have a patient who was pretty small pupils, like if they're 4, 5, then I would be more inclined to dilate to try and capture more data to do HOA correction. But the dark adaptation, try to maximize the pupil, and that's the most convenient, straightforward way of doing it.
Mhm.
And sometimes with dilation, the pupil gets way too big, and then you don't know where the actual center of that
Mhm.
the eye is. Hmm.
Great. Well, that's been a wonderful presentation. Thank you so very much. I always learn so much from you. I actually made a few notes of a few things along the way. And that's the beauty of our community with the opportunity to have this time together for education and webinars is, no matter how much you do or how little, there's always clinical pearls to take away. Anybody that would like info, I mean, it's one of our greatest assets would be connections with industry, truthfully. I found it's really elevated my career. So I thank everybody that has invited me to participate in this webinar. And Dr. Wong, you've been a huge supporter as well over the years. And so this is information if you'd like to email OVITZ or Eaglet. And I see that there's one question in the chat, and I think that I'll give that to you where seems like aberrometry is quite quick. Do you measure on all your scleral lens patients, Dr. Wong?
I think it's helpful to know if that's something, if HOA is going to be something I'm going to bring up. Partly it's practice builder and also bring up, sorry, identifying who the candidates are because I would hate for them to bring it up to me first and then be like, hey, why didn't you know
Yeah,
this when you do, specialty lenses? So I do recommend yeah, at least majority of the patients to screen for the scleral lenses.
great.
Screen. rose-colored lenses. Yeah. Hmm.
Perfect. Well, thank you so very much.
All
Uh,
right. Thank you so much, Dr. Morrison. I'll see you at ICSC.
see you for the next round. Can't wait. Thanks again, everybody.
Thank you, everyone.